Before a doctor says the words, "You have cancer," a process begins. We look beyond the diagnosis to the careful work that turns uncertainty into answers.
Radiology plays a very integral role when you're looking at diagnosing cancers. So you can start a patient journey in diagnosis of cancer. Initially they feel there is a problem, a symptom, they see a doctor, and the doctor then picks up that maybe this could be a cancer or a particular organ. So that's where we come in then. We scan that organ. We have various modalities like CT, MRI, ultrasound, PET-CT, where we can look at the body, inside the body, and we can pick up where this cancer is or is not there. And if we pick up where the cancer is, then we can also determine how we can go in and take a little bit of the tissue out. And that's many times we come into the picture by using imaging guidance, putting a needle, using imaging, say ultrasound or any other modality, taking out a bit of tissue, and then sending it to pathology. How do we determine whether it's spread and how far it has spread? Again, that's where radiology comes in, because we can scan the whole body. We have multiple scans. Like in many of these cases, we do a PET-CT scan, which scans from head to toe. And we can determine has the tumor spread to other places or not. And our images are very sensitive in picking up these spread very early stage. So by that we stage the tumor. Is it an early stage or is it a late stage? And the treatment varies based on whether it's early stage or not. Early, maybe you can just take the tumor out. But if it's late stage, it won't help just to take the tumor out because you've got disease elsewhere. So you have to manage the patient more systematically. You may have to do chemotherapy or other treatments that are available there to treat the cancer as a whole.
But pictures alone cannot tell the whole story. To understand what we are seeing, we must look closer, beyond the image, into the cells themselves.
When it comes to the lab specifically, as a pathologist, what I usually start with is what is the clinical presentation of this patient, what are the imaging findings, and then where is the biopsy from. So let's say if it's a biopsy or if it's a blood sample, right? So for leukemias, we use blood samples, we do biopsies, bone marrow biopsies as an example. But let's say if it's a breast mass in a woman, then we do a biopsy of the breast mass. But then I need to also see what did the mammogram show, what did the ultrasound show. So when I'm looking at that biopsy, I have all that information in the background. So that's why it's key to understand that cancer diagnosis is a multidisciplinary approach. Once we have done that, the type of cancer that we diagnose gives an indication of the prognosis. How is this cancer likely to behave? And that's important for the clinician to know that if this is the diagnosis, how is this cancer likely to behave with or without treatment?
With answers from the lab and clarity from imaging, the journey moves forward to decisions that can change a life.
It's important for us to understand why has a patient in her 20s, 30s, 40s, maybe even early 50s developed breast cancer. And what we do is we run genetic testing to try and understand. Now, the vast majority of patients, we may not find a faulty gene, but there is a substantial number where we will find a faulty gene. And substantial, I mean, it's important for that patient to understand that we have found the genetic driver for your cancer at a young age and give you targeted treatment that will target that gene and lead to better patient outcomes. But it goes beyond breast cancer. In-house at Aga Khan, we will be testing for genetic mutations in not only breast, but lung, colon cancer, prostate, ovarian cancer. Beyond these ones, we have great links with labs outside Kenya where we would send a patient specimen, be it lab or the biopsy material, to assess whether there are any mutations that are driving their cancer and can be targeted with personalized treatment. There are internationally held guidelines for almost all cancers at all stages. And so that is what we sit down and discuss. For instance, we would say this patient has a stage 2 breast cancer that is hormonally driven. What is the current and most recent evidence that would support the treatment for this patient? So we would sit, deliberate, ensure that that treatment is in fact the right treatment for the patient we have in front of us, and then present that to the patient. So it's evidence-based treatment that is discussed and agreed upon in the tumor board setting, presented to the patient, and if we're all in agreement, we proceed with the treatment.
But cancer care doesn't stop at treatment. It also looks to the future, towards better options, better outcomes, and new hope.
Clinical research is important because It is a process that we use to make sure that drugs and diagnostics are safe and effective for our population. It's important for us to be able to conduct clinical trials in Kenya, in sub-Saharan Africa in general, because in the past, most of these clinical trials have been conducted in the West, and we are genetically diverse population. We're very different, and we need to make sure that these drugs are safe and effective in our population as well. Since the inception of the Clinical Research Unit in 2020, we've participated in over 15 clinical trials and enrolled over 500 patients. Some of our patients have achieved good clinical response to this treatment, and we've had some of our cancer patients go into remission, which means that the cancer can no longer be detected in their body. We've also had vaccine studies, and we've had our patients protected from illnesses that they would be exposed to in their community. And then we've also been able to generate knowledge specific to the Kenyan population that we know will benefit us moving forward.
But there is a moment in every cancer journey that can change everything the moment cancer is found early.
If you were to look up today what the survival of a patient with stage 1 breast cancer is, you will be, I hope, pleasantly surprised to see that at 5 years, more than 90% of patients with stage 1 breast cancer are alive and well without any evidence of disease. And compare that to a patient with stage 4 breast cancer, that at 5 years, only around 30 to 40% of that group of patients will be alive, living with their disease with treatment that is keeping it under control. Hence the emphasis for screening, right? So not all cancers lend themselves to screening. Certainly breast cancers do. From the age of 40, we have a great screening program, a great breast cancer program that will look after patients. We will guide you as to how often your screening should be done. Screening for cervical cancer, screening for colon cancer, screening for prostate cancer. The earlier the diagnosis, not only is your survival going to be longer, but the treatment itself is not as arduous as for someone who has much more advanced treatment that will require ongoing treatment, not just for weeks or months, but for years to keep the disease under control.
From the first test to the final treatment and beyond cancer care is a journey taken together.
On this World Cancer Day, we are committed to our patients who fight this battle every day of their lives. We're committed and celebrate our staff, nurses, physicians, clinical staff, who are there by their sides every day as well. We celebrate the high technology we have here, committed and dedicated to cancer care, and most importantly, we're committed to research, the drug called hope, so that we may discover the treatments of tomorrow for our patients here at AKU and in Africa.